Thank you very much for the introduction. Good afternoon. It's a pleasure to speak in such a full room, I have to say, and it's an honor to be invited. I talk about the non-traumatic thoracic emergencies. Acute chest pain in the emergency room is the second most common reason for patients presenting to the emergency room, with more than 6 million visits in the US. Almost 1/3 of them actually refer to acute coronary ischemia. On the other hand, there is a plethora of possible causes associated with different risk conditions presenting with acute chest pain. And you can divide that in high risk, in intermediate risk, and in low risk patients. And I mainly want to cover with you some aspects of high risk patients, as you can see here. It would be not a good talk if we would not talk about acute chest pain and triple rule out. So if you follow the ACR appropriateness criteria for patients with acute non-specific chest pain, published in 2012, they recommend for patients with a low probability for acute coronary syndrome, a chest X-ray as the initial imaging method to identify pneumothorax, pneumomediastinum pneumonia, or fractured ribs. The second step is a CT to diagnose non-cardiac causes such as pneumonia, pulmonary airspace abnormalities, pneumothorax, or mediastinal pathology. And CTA is actually recommended to diagnose or rule out PE, aortic syndrome, and coronary artery disease because of its excellent negative predictive value to rule out CAT in low-risk patients. Protocols for triple rule-out depend very much on the scanners you have at home. So let's start with the 64-slice scanner. You can do that with retrospective triggering or prospective triggering. Retrospective triggering, of course, in association with the dose is certainly not recommended. If you go for prospective triggering, you have the limitation of heart rate and arrhythmia. If you have a more modern scanner, like a 320 detector row with a more than 60 centimeter wide detector arrow, then protocols which have been suggested in the literature are that you do 2 sequential, non-ECG-gated, non-spiral scans over the whole chest with a delay in between of 1.4 seconds, just to cover the whole chest, and then a third ECG-gated scan only over the heart after 7 seconds of delay. If you have another more modern dual-source CT scanner, you can use a high-pitch mode with an effective pitch of 3.4 to cover the whole chest in less than 1 second. And you do that with ECG synchronization to cover the core in the good phase in the late diastole. And these are images from the literature, different images using modern scanners, and just to show you that these protocols are indeed able to give you a very good and absolutely sufficient contrast for evaluation of the aorta, of the pulmonary arteries, and of the coronaries, as you can see here. And another, later on I'll show you more pictures. The most challenging task, talking about the triple rule-out, is actually how to ingest the contrast. And again, if you go into the literature, there is a broad range of protocols which have been suggested, ranging from 3-phase to biphase to monophase protocols. So starting here with the 3-phase protocol, they actually start with a relatively or moderate contrast concentration, first injected undiluted to build up a high contrast, and then followed by a diluted and a saline chaser. Very similar are the other protocols. They first inject with a high injection rate to build up the intravascular contrast, followed by a smaller bolus with a slower injection just to lengthen the plateau phase. And that can be done also in a monophasic way, as you can see here. You see, these are relatively high volumes of contrast injected. There is alternatively also a low contrast media volume protocol suggested in the literature, going down to 60 milliliter. What they do to compensate for that, they actually go to a higher concentration injected with a relatively high rate, as you can see here. And these are, again, pictures from the literature. This was obtained with a protocol with a 320-row scanner, and you see the 2 chest scans here, and then followed by a third scan here to cover the coronary arteries. You can only do that trying to catch the aorta, the pulmonary vasculature, and the coronary arteries, triple rule out, if you have proven beforehand that this protocol is at least comparable to a dedicated cardiac CT. So for that purpose, I went back to a meta-analysis published in 2013, and just to summarize that. In terms of image quality, they looked at 4 studies, and they couldn't find a significant difference between the 2 protocols. In terms of diagnostic accuracy, triple rule-out versus dedicated coronary CTA, they did not find a significant difference, both achieving a sensitivity and specificity around the 90%. And again, they included 4 appropriate studies for that. However, they did find, and we are not surprised about that, a significant difference with respect to radiation exposure and with respect to contrast volume if they compare the triple rule-out with the dedicated cardiac CTA. These are images just to show you what you can achieve with a one-step scan, showing here pulmonary embolism and at the same time a small intravascular defect in coronary arteries. And this is for a multiple-step protocol, again showing equally good quality in all 3 vascular areas. Unanswered questions talking about that, and also going back to what I just told you in terms of dose and contrast medium volume injection, it has to be asked critically that in these studies there was an extremely low rate of pulmonary embolism and acute aortic syndromes. All in this meta-analysis, 8 patients with PE in 4 out of 10 studies and none with acute aortic syndrome. So we have to ask ourselves a little bit, do I really need that? Is this enough justification for extending the scan range and using more dose and more contrast volume? It requires a very careful selection of patients, and actually it has been stated that it is only applicable or should only be applied to older patients with a low, and I come later back, intermediate risk, and future studies are actually needed to assess the outcome, the clinical yield, and the incidental findings and costs of these protocols. So in summary, for high-risk patients, catheterization is recommended. And we just discussed for low-risk patients, CT is recommended to rule out both acute coronary syndrome and especially all the other alternative diagnoses. And actually, if you go to the literature for intermediate risk, there are no consistent criteria. What is actually the definition of intermediate risk? And these patients, they probably need extended technical and laboratory diagnostics, inclusive stress tests, and dedicated cardiac CTA. And I want to finish this topic of the triple rule-out with the following. With advanced CT technology, it is possible to perform a single-phase triple rule-out examination allowing comprehensive assessment of cut, aortic dissection, and PE, as I could show you with the images. However, and this is a citation of this ACR Appropriateness publication, its efficiency or effectiveness has not been demonstrated. The next topic I want to discuss with you is acute pulmonary embolism. And I want to start with a very nice review, which was titled, How CTPA Finds Emboli That Do Not Need to Be Found. There is an explosion in use of CT imaging in the years between 2008 and 2008, 14-fold increase of application of CTPA examinations. There is, from a statistical point of view, evidence for overdiagnosis, because on one side there is an 80% increase of PE diagnosis, but the age-adjusted mortality from PE did not change. And we have to ask ourselves, or better not ourselves, but actually the clinicians, whether it is not possible to assess more appropriately and more accurately the pre-test probability. And this was a study using different risks for thromboembolic, different risk factors for thromboembolic disease to find out whether these cannot be used to target CTPA more appropriately than currently done to decrease the costs and thus also the radiation. And they looked not at the classic factors, for example, in the Wells score. They looked at immobilization, hypercoagulable state, and prior PE and or DVT, and these were the most important factors. And they actually find in a quite large group of patients that without any of these thromboembolic risk factors, it was extremely unlikely that the patient would have a positive CTPA. So it is actually a way that we have to consider a more close collaboration with the clinicians in terms of the referral criteria for CTPA. You're all familiar with the diagnostic criteria for acute pulmonary embolism. That are the acute angles, the complete vascular occlusion, the enlarged calibers of vascular structures, so-called Polo-Min sign, the sharply defined intrapulmonary defect, railway track signs. And these intravascular defects, if they are acute, have a relatively low density and are sharply defined, as opposed to signs of chronic pulmonary embolism, where the intravascular defects have a little bit higher density. They used to be more wall adherent. We have some webs, intravascular webs. We have irregular vascular calibers, not an enlarged caliber, but a smaller vascular caliber, and as I said already, a wall adherence of the intravascular defects. Many studies have been published and also are here discussed about the CT signs for prognostic purpose and to find out whether there is increased risk for right heart dysfunction. And I just go with you through some of these features. You look at the ratio between the right ventricle and the left ventricle. What you do is you measure the maximum transverse diameter in the minor axis. And that actually has to be done not on the same level, which would be the easiest for us to do, but if you really want to do it correctly, on a different level, mostly on those images that show really the walls between the atrium and the ventricle, and it has to be measured between the inner surface of the free wall and the septum. Another factor is the ratio between the pulmonary artery and the aorta. And this should be done on an image which is the direct continuity between the right main pulmonary artery and the pulmonary trunk. You look at the morphology of the intraventricular septum, and you look whether there is retrograde contrast media reflux into the inferior vena cava or into the hepatic vein. However, you have to be careful. Just reflux into the inferior vena cava or just the proximal part of the hepatic vein is actually also seen in patients with a perfectly right ventricular function, and it has to do also with the inspiration level and the flow of the contrast media rate. This is an example of the heavily enlarged right atrium and right ventricle with a bowing of the septa. Points of discussions are that no correlation could be found between clot burden on one side and short-term mortality, and the effect between clot burden on one side and long-term mortality is not yet known. There was no good correlation between clot burden and the perfusion index, and that also has to do with a different study population and the different criteria of inclusion in heavily influencing those statistics. Also, if you go to the literature and just look at the ratio between the right ventricle and the left ventricle, there's a variability in terms of the cutoff values. Some use a larger or equal to 1, larger 1, 1.1, 1.5. So there is actually no broad consensus about it. Whether you should use subjective or objective assessments, and I come to that later back. And then you can do that just on axial views, very easy, but you can also do that on elaborate four-chamber views or volumetric assessment. And in fact, that has been compared just on axial slices, on reconstructed four-chamber views and volumetry, but they could not find a significant difference between these different methods. So it seems to be that if we do it appropriately, just on axial views, that is absolutely sufficient. We are all familiar with these perfusion images, which can be gained using a dual energy technique, as you can see here, and it allows perfectly visual assessment and also quantification of the resulting perfusion defects. Many studies have evaluated that, and they found a good correlation between signs of right ventricular dysfunction, for example, here the RV-LV ratio, different scores using the Canadli score or the Mastora score, and those perfusion defects in dual energy images. How much dose do we need? And there are many strategies for dose reduction. You can lower the kVp to 100 kVp or even 80 kVp in smaller patients. You should use most modern iterative noise reconstruction, but the most easy and probably underestimate to reduce the dose is just limit the scan range. Not covering the complete chest, but just maybe 2 centimeters above the aortic arch and 2 centimeters below the inferior pulmonary vein, or even smaller. And there are multiple studies, and the most recent one from 2013, who actually did not find a significant loss of important diagnosis by cutting down this scan range. I am not advertising here that we should cut down the scan range in any patient, but let's say if I have a relatively young patient, if I have a relatively low risk or pretest probability, then you should consider to do so. PE diagnosis during pregnancy. In 2011, there was an official ATS-STR clinical practice guideline published, including 7 recommendations. D-dimer is not suited to exclude PE. If the pregnant patient is coming and has signs of DVT, the first method we should apply is an ultrasound. If this ultrasound is positive, then we have the diagnosis and it's fine. If the ultrasound is negative, we have to do further testing. However, if the patient does not have any DVT signs, we should go immediately to the examination of the pulmonary vasculature. And now it becomes more interesting. They say, according to these guidelines, the first what you should do is a chest X-ray to use for triage. And if this chest X-ray is normal, the recommendation is to do a scintigraphy. If the chest X-ray is abnormal, because then you have a high risk of a non-diagnostic VQ scan, then you should go to a CT. And the reason why they gave a certain preference to scintigraphy is the following. Despite the fact that the dose for the fetus is slightly higher using scintigraphy, there is a huge difference in terms of dose for the breasts of the woman. And that was actually the reason why these recommendations came to the consensus to recommend scintigraphy. And in these dose values, they have not yet taken into account that you can actually skip the ventilation part and just go only to the perfusion part. There have been studies who have compared this, lung scintigraphy versus CTPA during pregnancy. And Marie-Pierre Revel from France, she found a comparable diagnostic performance, comparable numbers in terms of positive for PE, in terms of indeterminate studies. She found a higher inter-reader agreement for CTPA, looking at the discrepancies here. But marked in red, the most alarming part was that she found in only 50% of the CTPA examinations an acceptable intravascular opacification considered to be good. And the reason for that is the following. The total blood volume increases during early pregnancy already by more than 50%. There's an increase of cardiac output in these patients, especially in the second trimester of the pregnancy. And this is the most alarming thing here, is there is a 6 times increased thoraco-abdominal pump, meaning if these patients take a deep breath, then you have this valley, more or less, in the intravascular contrast. And that is the reason why we frequently see a bad intravascular contrast in CTPA during pregnancy. So what you should do if you do a CTPA, you should adapt your protocol in these patients. And how do you do that? You reduce your kVp to reduce the dose. You should increase your flow to compensate for this hypervascularization, and you should increase your iodine concentration, shorten your delay, and you should definitely tailor your volume of the contrast to your scan time. If you have a very fast scanner, you need less contrast. And you should ask the patients not to take a deep inspiration, but let them shallowly breathing. The next, and you have seen already beautiful images from the aortic syndrome, I just want to cover a little bit aspects of the non-traumatic issues. Acute aortic syndrome includes a spectrum of conditions which have in common an acute, irreversible change of the aortic wall, and it includes dissection, the intramural hematoma, and the penetrating atherosclerotic ulcer. Starting with a penetrating ulcer, it is caused by rupture of an ateromatous plaque after erosing the internal elastic lamina, as you can see here, leading to this kind of penetrating a crater into the wall. And if this goes further on, then we have this little bulging, as you can see here on this image. It may move on to an intramural hematoma, to a limited intramedial dissection, or, as I said, to a saccular pseudoaneurysm. And these are examples where you see here this kind of ulceration out of the wall. The second is an intramural hematoma, which is caused by the rupture of vasa vasorum. It can be post-traumatic, but it can also be the consequence of an ulcer. It is considered a precursor of dissection. In almost 50%, it can move on to a real dissection, but in a smaller part of patients, there might be also regression. And in most of the patients, it occurs in the descending aorta. And here you see images without contrast injection. With contrast injection, you see the increased thickening here of the aortic wall, which is much more easily appreciated if you do a CT first without contrast application and then later on. But if you are familiar with the findings, then you see also that the lumen, the contrasted lumen of the aorta is changed due to the circular thickening of the aortic wall, described as an elliptical deformity. Aortic dissection is caused by an intimal flap, by a tear within the aortic intima. Blood passes through the tear, separating the intima from the media and the adventitia and creating a false lumen. This dissection can move anterograde or retrograde, and then the distinction between the true and the false lumen is fundamental for the treatment, as we all know, and the most broadly applied classification is the Stanford A and B classification, dependent on the fact whether the ascending aorta is involved or not involved. And I show you some pictures here from a type A dissection, showing here the enlarged ascending aorta with the different lumina, as you can see here, the sagittal reconstructions in the same patient over here. Another complication in a patient here with a type B dissection. We see that only the descending part peripherally from the origo of the left subclavian artery is involved, but we see also the complication here. We see an ulcer here, and we see a huge hematothorax in this particular patient. And these are the corresponding reformations. By the way, these are relatively old images, not ECG triggered. You see the pulsation artifacts. So even with older scanners, appropriate intravascular contrast, you are able to do these diagnoses. Complications of an aortic dissection B, which is most of the time treated conservatively, is dependent on the fact whether there is an entry. The ratio between the true and the false lumen, and whether the true lumen is completely compressed, potentially leading to complications such as, for example, here we see that the mesenteric artery is only partially perfused over here, or the renal artery on the right side. The last part I want to cover only very shortly, and more cases we will discuss later in the interactive part, is the extensive parenchymal opacification. And I start with the white lung on ICU. First patient, second patient, third patient. The underlying reasons were ARDS, pneumonia, and edema, and you are all familiar with the fact that these broad, extended intrapulmonary consolidations cannot be further differentiated without further follow-ups or clinical information on a chest X-ray. It's not only difficult on a chest X-ray, it's equally difficult also on a CT, as you can see here, a patient with ARDS, a patient with edema, and a patient with a bilateral pneumococcus pneumonia, and that is more or less described as the fact alveolar filling. All the alveolar spaces are just filled in with something, whether this is blood, whether this is edema, whether this are infectious cells, cannot be further differentiated. Talking about edema, we are most familiar with these classic forms, like the interstitial edema and the alveolar edema. On CT in interstitial edema, we want to see thickened interlobular septa, as you can see here, a little bit thickening also of the bronchial walls, so-called cuffing. We see some enlarged vessels. On the other hand, in an alveolar edema, we see consolidations, more or less symmetric, with a subpleural sparing. This is what is described as typical in the books, and then we also don't have problems to diagnose that. But I named it the many phases of edema in CT. The problem is that we are not used to the fact that we have patients with just an edema on the CT scanner, but we have to consider it in our differential diagnosis. So we can see patients with only ground glass, as you can see here. Again, a little bit the subpleural sparing. We can see almost lobular, a pattern sharply demarcated by the interlobular septa with a crazy paving. I have no idea why big parts of the lung are not infected and only more or less the central peribronchial vascular areas are affected in this particular patient. Or we have dense consolidations, as we can see here, and if we are lucky, in a ventral-dorsal gradient because the patient is lying on his back, and then we have this normal transparency, ground glass transparency, and consolidations. Very similar images we have in patients with ARDS or DAD, diffuse alveolar damage, and this was a patient with rheumatoid arthritis. Later on, he developed here these effects of barotrauma, as you can see here. And talking about barotrauma, we want to see the CT signs early, not when the patient has a bilateral pneumothorax, but also see the more subtle signs as interstitial emphysema, as we can see here, around the main bronchus and here around the artery. If you go into the literature and you just look for the combination of acute and respiratory failure, then you find acute cardiac decompensation, acute respiratory distress syndrome, acute exogenic allergic alveolitis, and so on and so on. And that makes it so difficult, A, to present, but also for our differential diagnosis. Just a classic example of exogenic allergic alveolitis. We see here the lobular areas with air trapping as opposed to ground glass. There is no underlying destruction of the lung parenchyma because this was more or less an acute allergic or subacute allergic alveolitis. Another patient with a diffuse increased density of the lung parenchyma due to bleeding. This was a capillaritis in the patient with systemic lupus erythematosus, a little bit of ventrodorsal gradient. These patients are heavily ill. Not necessarily these patients have hemoptysis, despite the fact that all the lung is actually full with blood. So in summary, I discussed with you imaging, and thus the radiologist plays a crucial role in the network, in the workup of non-traumatic thoracic emergencies. We discussed a little bit the role of triple rule-out in atypical chest pain, aspects of PE and aortic syndromes, and I just touched the differential diagnosis of acute diffuse pulmonary disease, and we will see more cases in the interactive part. Thank you very much for your attention.